A very good evening to all in the East Coast, good afternoon to the West Coast, and very early or good morning to Europe and Asia. We're super delighted to conclude our ASCO series with lung cancer this evening. Just to recall, these are all the series that happened in the town hall of that focused on ASCO for the last couple of days. The thinkers at the think tank has been busy providing you with some of the highlights of the key data that happened in RCC, prostate cancer, breast, GI tumors as well. These are available on YouTube, as well as some of our LinkedIn videos are available through LinkedIn and other social media. Super excited to invite our panel, friends of the shop of the think tank, Dr. Corey Langer and Dr. Borgai, who are leading the thoracic in their institutions of UPenn and Fox Chase. As we go into the next frontier of lung cancer, I would love to listen to Dr. Langer and see what's happening in the Langer household.
Thank you, Hafiz. This is the latest addition to the extended Langer family household. This is my new grandson, Maurice Josiah Langer, quite a name, born just last week, exactly 1 week ago. He doesn't look anything like the swaddled baby anymore. It's amazing how quickly they flesh out. I would call this the next generation, not necessarily the next frontier, but who knows? But we're pleased as punch to include him. He's now our third grandchild. It's what happens as you get older. You start accumulating not just children, but grandchildren. So thanks for calling him out.
Perfect. Mazel tov. Congratulations to you and the family as well. So as you can see the agenda, we're going to keep it brief in terms of highlighting key topics. Of course, you're here to listen to Dr. Borgai and Dr. Langer in terms of what they're thinking about some of the data. We'll spend the evening discussing IO in adjuvant as well as neoadjuvant setting with some of the IO successes we have seen in breast cancer. So super excited to see how it's evolving in lung cancer as well. Then we head over to IO in late stage. And then I know all of you, or some of you, are very excited to hear some of the advances in targeted agents as well. And then we'll basically conclude with the targeted agents. So with that, I hand it over to Dr. Langer.
Thank you, Fias. So we're going to start out with Empower 010 and Checkmate 816. The former, the Empower trial, is without question, in my mind, a game changer. It's going to potentially alter therapeutic practice. I think jury's out on Checkmate 816. We'll go to the next slide. So this is the design of 010. Is presented by Heather Wakely at the lung thoracic plenary session. And a fairly straightforward approach, a direct comparison of Atezo to best supportive care, not placebo, after completing adjuvant chemotherapy, platinum-based treatment in resected stage 1B to 3A on non-small cell. Tissue had to be adequate for Pdl1 analysis, but you were not required to be Pdl1 positive to go on this trial. Stratifications included gender, stage with 1B versus 2 versus 3A histology, and of course Pdl1 status. And this used the Genentech Roche assay, the SP263, not the Merck assay as the stratification. You can see the primary endpoint was investigator assessed disease-free survival, and then this hierarchical statistical analysis, first in the stage 2 and 3A population for Pdl1 positive, then all randomized stage 2 and 3A, and then finally intent to treat population, including all participants. OS is a key secondary endpoint, but it was not primary. And again, the randomization occurred not after surgery, but after the completion of adjuvant chemo, with 1,280 patients ultimately enrolled. Next slide. Very busy slide, but this summarizes the demographics. You can see that both arms were very well balanced. Of note, not all 1,280 actually went on to treatment. Roughly 80%, or 1,005 patients, went on to the randomization. So I think it's important to ultimately figure out what happened to that 200 or so who did not. If you look at the basic population, roughly 62% in non-squamous histology. For the main analysis, the first analysis, Pdl1 positive, 100% obviously, were Pdl1 by the assay. But for the all randomized patients, it's only about 58%. So this assay distinguishes itself to some extent from the Merck assay, where you'd expect about 2/3 of all patients to be PDL1 positive. And note as well, patients were not excluded if they had EGFR mutation or ALK rearrangements. Roughly 8 to 9% of those are PDL1 positive, EGFR positive. All comers 11 to 13%. Again, more likely to see EGFR, for that matter, ALK in those who are PDL1 negative. The ALK rearrangements are anywhere from about 4 to 5%. Next slide. So this is the main result. The game changer is shown on the left. We see a 12% absolute improvement in disease-free survival in the PDL1 group in stage 2 and 3A patients who are in fact PDL1 positive. Median DFS has not been reached in the atezo group compared to best supportive care at 35 months. In the middle group is disease-free survival in all randomized patients, again statistically significant, but the hazard ratio climbs from 0.66 in the PDL1 group to 0.79, and note that the p-value drops off from 0.004 to 0.02, with roughly about a 6% absolute improvement in disease-free survival at 3 years. And then finally, all comers intent to treat. It looks significant, but based on the analysis that was conducted a priori, this has not yet crossed the significance boundary at this interim analysis. The stratified hazard ratio of 0.81 and a p-value of 0.04, with roughly a 5% difference in overall outcome. So as you get to lower stage and non-PDL1 positive patients, you're beginning to dilute the putative benefit of atezo in this setting. Next slide. This is the breakdown in that PDL1 positive group. Intriguingly, if you look on the right with the dashed red lines, at least in the EGFR group, very small numbers, but those who are EGFR mutant positive, the hazard ratio here is 0.57. And this is in stark contrast to what we've seen in advanced disease, where these agents, at least as single agents, we tend not to use, certainly not up front, but more in the second, third, or fourth line setting. ALK, very small numbers, 23 patients, very wide confidence intervals, a hazard ratio of 1.05. And again, the hazard rate, the confidence intervals for EGFR do cross unity. Intriguingly, current smokers, very small numbers, do not seem to be deriving the benefit that never or previous smokers. But once more, these are sub-analysis. For the much larger groups, based on age, gender, race, no major differences. I should point out, though, that it's N1 and N2 patients in the right-hand column seem to benefit the most. N1 has a ratio of 0.59, N2 0.66. N0, with the modern staging system, many of these are stage 2, although in the older staging system, they all would have been N1 or N2. The hazard ratio here is much closer to unity with wide confidence intervals. So that brings up another point, that probably the greatest benefit for this approach is going to be N1, N2 PDL1 positive. Next slide.
So Corey, let me ask a couple of questions if you don't mind. So
sure.
As far as the end stage and all that is concerned, this is beginning to sound like the original adjuvant chemo studies. The higher the stage, the more the benefit. So you're sort of beginning to see very similar patterns emerging. The question is, I don't recall if this was part of the presentation or not, but was post-op radiation for N2 disease allowed?
I don't believe it was formally part of the study. Whether it was allowed or not, I'm not sure, but it definitely wasn't a formal part. And I suppose we can go back to the beginning and look at the eligibility, but I don't believe these folks were routinely radiated.
And then the EGFR story is also kind of interesting, because this is now a little bit, even though the confidence intervals are really large and it's small numbers, but we did not see this benefit in Pacific when they
not at all, not to this extent. The hazard ratio was to the left of unity, but the confidence intervals overlap. The numbers in Pacific are even lower than we see here. So these are hypothesis generating. We're talking all of 43 patients, 40% or so were EGFR unknown, and they seem to have the same benefits as EGFR negative. So I would not draw firm conclusions here. I'd be a little bit more confident about the nodal conclusions.
Good, yeah.
Next slide. And then this actually looks at a breakdown of Pdl1 status. So those are 50% or higher. Hazard ratio is 0.43. For 1% or higher, that goes up to 0.66. So this begs the question, what on earth happened to the 1 to 49% group? If you do the math here, that's roughly 250 patients. And if you do by inference, the hazard ratio in that group is probably going to be quite a bit higher than 0.66, probably closer to 0.90. So we eagerly await the analysis for the 1 to 49% group.
Are you suggesting that perhaps the benefit we are seeing is strictly in the VD PDL1 high group?
Oh, I think it might also be in the intermediate group, but certainly one would infer from this that the benefit's not going to be as pronounced.
Okay.
And for PDL1 negative, which is 383 patients, the hazard ratio basically is unity. It's 0.97. And note here, and this is all randomized, so this includes the PDL1 zeros, the EGFR mutation status no longer has that hazard ratio of 0.59. It's climbed to 0.99. So the implication is if you have an EGFR mutation, no PDL1 expression, your hazard ratio is going to be on the other side of unity. It's probably going to be about 1.4. So certainly not offer this to a PDL1 negative EGFR mutant patient, where Adora would be the standard, presumably. Osimertinib would certainly have a preferential role in node positive resected patients post-adjuvant chemo. Next slide. And this is very preliminary. This is the survival analysis. It's immature. What's gratifying, at least, is that we are seeing some separation in the curves. On the left, again, for the group most likely to benefit, PDL1 positive stage 2 and 3A, hazard ratio of 0.77. But at this point, in the intent to treat population, survival has not been formally tested. Nevertheless, a trend that I think is favorable. Next slide. And here's toxicity, no major surprises. We're seeing the usual gamut of immune-mediated AEs. The vast majority are grade 1 or 2. Only about 8% or so are grade 3 or 4. And treatment discontinuation, relatively uncommon here for atezo, 18% or so having AEs leading to atezo discontinuation, a higher number, nearly 30% having dose interruptions. Be very interesting to see if, as we've seen now in advanced disease, whether AEs do in fact correlate with better outcome. Immune-mediated events may actually be a marker in and of themselves for potent benefit in this setting. Next slide. So that's the very brief overview of 010. This is 816. I would not consider. Oh, go ahead, Haas. Yeah.
When the Pacific was first reported based on PFS, you insisted that OS would be important for a potentially curable patient population. Presumably, and we don't know, no, seriously, if the FDA approves this, first of all, would you advocate for approval in all comers or only PDL1 positive? And second, would you have a problem with going with just DFS and not OS? And I think, I don't remember which side of the argument you fell under when the Adora was reported. So I don't remember whether you were for OS or was DFS enough. And I just want to know what your take is.
So initially, for all of those studies, I was for OS. However, my experience with Pacific has, shall we say, altered my impression of the benefits of immunotherapy. And if you're seeing a separation in the curves, by and large, not always, but nearly invariably, that PFS benefit will translate into an OS benefit. All bets are off. We don't know that for a fact. Once the OS data came out, and I'm going to show an update imminently for Pacific, I became clearly a believer in the locally advanced setting. Adora, my attitude is a bit more nuanced. I offer it with enthusiasm for stage 3A, with a little bit of caution for node positive stage 2, with some trepidation for 1Bs. I think the brain metastasis, the protection that we've seen in the brain with ADAURA has swayed me. Whereas I was firmly a fence sitter before, maybe leaning more toward OS, I am now leaning toward that DFS analysis, thanks to the subsequent presentation on CNS protection
Okay.
for osimertinib.
Yeah.
In this setting, to make your hopefully a shorter answer, I will offer it to PDL1 positive, node positive for sure. I think beyond that, I'm going to have major ambivalence, and it'll certainly be shared treatment decision making. For the node positive, based on the DFS analysis and that nice separation that we're starting to see, I won't mandate it, but I'll certainly strongly advise it.
Okay, so we have a question that's asking if there is a concern because for grade 5 toxicity in this relatively healthy population. Of course, we don't want to see grade 5 toxicity, but I don't know if the percentages were that high in the treatment group.
Can we go back a slide or two? So treatment-related grade 5 AEs, there were 8 AEs overall in that group compared to 3 in the best supportive care. 4 were grade 5. I think if we go back to, remember this is over 1,000 patients, so the rate is less than 1%. While that seems quite high, I think that's still, at least in my mind, within acceptable range. I mean, ideally, I'd like to see 0, but we are dealing with drugs that have sometimes unpredictable consequences.
I agree, yeah.
Next slide. So this is the treatment design of 816 in the neoadjuvant setting. So same basic population, 1B through 3A. Unlike the Empower trial, no known sensitizing EGFR mutation or ALK alteration. This was based in large part on the Nadim trial, which was conducted in 3A patients, where Nivo combined with chemo for 3 cycles led to major pathologic responses in nearly 60% of patients, in 70 to 80% of patients, and pathologic CRs in 3A disease in over 50% of patients. So with that as background and genesis, this laid the groundwork for a straightforward study design, chemo plus or minus Nivo for 3 cycles, neoadjuvant, pre-op, with surgery occurring within 6 weeks post-treatment. The primary endpoint here was path CR, as well as event-free survival. We don't have the data for the latter yet. And the key secondary endpoints included major pathologic response, overall survival, and time to death or distant metastasis, with the response rate and the feasibility of surgery being key exploratory endpoints. And feasibility of surgery is actually part of the ASCO presentation. The Aacr analysis centered on path CR. Next slide. So here's the primary endpoint as shown at Aacr. You see a major improvement, 24% path CRs. This is virtually unprecedented compared to just 2.2% for chemo alone. This is all comers, 1B through 3A. The secondary endpoint, major pathologic response, which is generally defined as 90% or greater pathologic regression, 37% versus 9%. You can see that both arms of this a much smaller trial compared to Empower were well balanced, with a roughly even split between squamous and non-squamous histology. The vast majority were current or former smokers, only about 11% were never smokers. And you can see an interesting distribution for PDL1, roughly half, 50%, 1% or higher, and the breakdown, 50% or higher was 20 to 25%, so an even distribution there as well. TMB, again, amongst those who were valuable, nearly half of those who were valuable had higher than 12.3 mutations per megabase. Next slide. So this is the breakdown for path CR. No surprise if you look at PDL1 status, well, actually a major surprise. Those who were less than 1%, the unweighted PCR looked relatively better in that group, 17% versus 3%. for PDL1 higher, 33% versus 2%. So a higher path CR rate in those who are positive, and no major distinction by histology, whether it was squamous or non-squamous. The 1Ds were more likely to have path CR, 40% versus 0 in the chemo-only group. When we get to stage 2A, 2B, and 3A, pretty consistent 23 to 24% having path CR. Next slide. The completeness of resection was numerically a little bit higher in the Nivo group, 83% versus 78% having R0 resections. And intriguingly, somewhat lower pneumonectomy rates in that 3A group. It's a little bit hard to see the actual numbers, but 17% versus 30% in that 3A group. So by and large, patients having more definitive surgery, more complete resections, and fewer undergoing more radical operations, which speaks against some of the preconceived notions some of our surgical colleagues had, that this fear that there would be more toxicity, harder operations. I've had some surgeons describe the surgical field as bleeding concrete. That was not the case amongst those who actually participated in this trial. Next slide. So some basic discussion topics, which I think we've partially centered on. Haas, do you think EMPOWER-010 will lead to an FDA approval?
Oh, I think it definitely will lead.
Yeah.
Yeah.
Do you think it'll be limited to the first analysis, or it'll be all comers?
I think they are going to limit it to PD-L1 positives, but that's my guess. But I agree with you that in a real clinical practice, it's going to be hard not to offer this for node positive, PD-L1 positive tumors.
Yeah, I think that's the group that I'm mostly going to offer to. If they make it a more expansive approval, I'm not sure I'm going to. I personally have reservations about offering this to either N0 or PD-L1 negative patients. Yeah, I guess my other question for you, I'm interested in your opinion on this. Are path CR major pathologic responses adequate surrogates for long-term outcome in the neoadjuvant setting, or should we still rely on DFS and OS? And do you think 816 is practice changing?
I think 816 is eventually going to be practice changing. So is path CR and MPR adequate surrogates? Well, depends on how you interpret it. Remember, in the old days, we used to look at the data for path CR in patients who had pancreas tumors, and those who got chemo-RT and went to surgery with the trimodality and had path CR invariably had better overall survival. So if you go back to the older data with that subpopulation, you already know that path CR, after some sort of an intervention can lead to better survival. And I have no reason to think that that's not going to be replicated here. However, I think from a regulatory point of view and practice point of view, we should at least have DFS data before we go ahead and change things.
I agree with you. All the data for path CR retrospective post hoc analyses, these are the first studies to really look at it prospectively and to really attempt to show direct correlation between PCR, DFS, and OS. And the data are just too early for either DFS and OS. My bigger concern is whether this is going to be adopted. The surgeons I work with like to operate, and delaying that surgery, particularly in folks who are resectable up front, is going to be a big river to cross. I'm not sure it's going to be so embraced. Ultimately, I envision studies that will be comparing neoadjuvant to adjuvant. I'm amused by the last question. What does this mean for metastatic patients? If we can prevent patients from developing metastasis, who cares? And if they do recur or relapse at some removed from their adjuvant checkpoint inhibitor, I can guarantee you they're going to be re-exposed to the checkpoint inhibitor. We should live long enough to worry about the lack of exposure to checkpoint inhibition in the metastatic recurrence setting.
I agree, absolutely. I think that would be a good thing. And there are other strategies that are in the works, and hopefully that would happen. And the penultimate question there, I think that we've already sort of floated a concept to see if we can do a comparison neoadjuvant versus adjuvant type of a treatment. But again, Dr. Langer remembers that these are not new ideas, comparing neoadjuvant to adjuvant. We've attempted to do this several times. Accrual has always been a problem. But Corey, I would also say the surgeons are physicians, and if you show them data that there's improvement in clinical efficacy, they will be willing to delay surgery if the outcome is good. So I think once we have survival data and DFS data, that discussion can be a lot smoother with the surgeons.
I think it'll be a lot smoother perhaps in higher stage patients, so the 3As where they might have qualms for doing surgery up front to begin with. It's going to be awful hard unless the data are overwhelming to convince our surgical colleagues when it comes to 1B patients who can easily.
But we already are seeing a little bit of a shift in the locally advanced anyway. I mean, patients who we used to try to make them surgically resectable, now we don't have a lot of problems offering them the Pacific style treatment. So I think, again, when the strength of the data can persuade people to change practice. So we'll see.
Well, you laid the groundwork for the next slide, Pacific data. Pacific isn't really late stage, it's locally advanced. I'd call that intermediate stage. These folks are still curable. And then we'll see updates on 9LA and 227, studies that Dr. Borgai actually participated in. So, and helped lead at least one of them. Next slide. So I think this audience is very familiar with Pacific 2-to-1 randomization of durva versus placebo in locally advanced patients who had completed chemoradiation. So remember, the shot clock starts ticking after the chemoradiation, not prior. This study does not account for the attrition that would occur during chemoradiation, either because of disease progression or untoward toxicity. Patients were randomized within 42 days of completing chemoradiation, so a bit sooner than we typically see in adjuvant trials. And the co-primary endpoints were both PFS and OS. We now have 5-year mature data after the last patient was randomized. Next slide. And here is the main upshot, that this PFS benefit that is now translated into survival benefit persists over time at 5 years, and you can see most of the tick marks now are to the right of that 5-year point. We're actually beyond 5 years. We see a consistent 9% absolute increase in survival. The 5-year stratified hazard ratio here is 0.72. The confidence intervals aren't anywhere near unity. And roughly a third of the patients accrued to this study who received durva remained free of progression in that group compared to 19% in the control arm, with the control arm clearly doing as well, if not better, than historic control. So any concern that somehow the control arm here is underperforming, I think, is put aside by this analysis. Next slide. And again, the all-important forest plots, by and large, every group benefiting. The non-squamous perhaps having a slightly greater benefit, a hazard ratio of 0.62 for survival compared to 0.82 for the squamous set. Pdl1s in a post-hoc analysis having greater benefit. If you look at 1% or higher, the hazard ratio here is 0.61. For those who are less than 1%, which is only 20% of all those accrued who had sufficient tissue, the hazard ratio is in the wrong direction, 1.15, and the EU has taken this to heart. Their approval for Pacific, for durva in this setting, is strictly in Pdl1 positive. The problem here is that this was a post-hoc analysis. Not everybody had Pdl1 assayed. We're not accounting for potential increased expression that might happen with Pdl1 after chemoradiation. We have no way of knowing that. The hazard ratios keep improving over time. The initial hazard ratio here was 1.39. It's now down to 1.15. If we look at EGFR, again, really small numbers. We're talking about 45 patients. For the EGFR negative population, no question that hazard ratio here is 0.66. But even for the EGFR group, it's 0.85 with very wide confidence intervals. There's no way the confidence intervals won't overlap unity in this setting. So for Pdl1 positive, for EGFR negative, a no-brainer. This is the standard approach. For those other groups, again, I think we have shared decision-making. Many of our colleagues, particularly those who are enmeshed in the EGFR world, like Heather Wakely and Leisha Sequist, will not give durva, period, to EGFR mutant patient. I think the conversation's a bit more nuanced than that, although certainly sufficient reason to have qualms about that approach. Next slide. And then finally, advanced disease, 9LA, as all are aware, chemo alone versus chemo for 2 cycles combined with ipi-nivo. Again, stage 4 recurrent or metastatic patients, treatment naive, no sensitizing EGFR mutations or ALK alterations, good performance status with primary endpoint necessarily overall survival, stratifications by gender, histology, and Pdl1 status. Next slide. So here we see mature follow-up now at 2 years, or shall I say maturing follow-up. We don't have 4 or 5 year survival, but the data are holding up a nearly 5-month improvement in median survival, a hazard ratio of 0.72, and at 2 years, 38% alive in the ipi-nivo arm compared to 26% chemo alone. Next slide. And once more, if we look at the breakdown, Pdl1 status matters not one whit. You have basically the same hazard ratio, whether you're richly Pdl1 positive, 50% or higher, or Pdl1 negative, 0.67. Histology, squamous perhaps having a relatively greater benefit, 0.63 hazard ratio compared to 0.78 for the non-squam group. CNS metastases, fairly big group, 123 patients, again, perhaps a relatively greater benefit, 0.47 hazard ratio. Next slide. And then 227, Dr. Borgai was intimately involved with. This is the long-term survival data. It was a very complicated trial with really 2 separate groups, Pdl1 positive and Pdl1 negative. We'll go to the ipi-nivo versus chemo cohort. Next slide. And here we do have much more mature data at 4 years, whether it's non-squamous or squamous. For Pdl1 positive, 29% alive compared to 18% with chemo alone, and virtually identical relative benefit. In fact, even more pronounced benefit in the less than 1% group. The hazard ratio of 0.64, 24% alive in the ipi-nivo arm compared to 10% for chemo alone. I know, Haas, that you've taken this to heart. And the less than 1%, you are considering this or the 9LA regimen for this group. I'm a little bit more circumspect. I would have equipoise, particularly in those less than 50%, directly comparing a 9LA regimen to histology appropriate chemo plus pembro. I think personally, I think it's a study that needs to be done. And needless to say, no one in industry is going to be interested in doing that. That's something that ultimately the cooperative groups will have to do.
No, I agree. Yeah, I have adopted the Pdl1 negative patient population. I'm using the 9LA almost sort of preferentially in that subgroup. The question always comes up: how do you decide between Keynote 189 and 227 and 9LA? And really, as you said, in the absence of some sort of a study comparing in these patient populations the 2 regimens, it's kind of hard to sort of know if there is a best regimen and what might work the best in one category versus the other. And I mean, at this point, I look at it as having options. My interpretation of data is that for the Pdl1 negative subpopulation, ipi-nivo offers a little bit more durability and longevity, but that's open to debate. Obviously, again, it's a little bit of an apples and oranges comparisons if you want to put this and compare it to Keynote 189, because the patient population is slightly different. So I think there are some remaining questions, and as you know, we have tried to propose a comparison in the Pdl1 negative population with the Keynote 189 versus 227, but I'm not sure where that proposal is going to go. So these are and remain debatable and questions that I think we have to decide personally as to how we want to proceed.
Do you have a histology basis for it? You'll offer 9LA to anyone who, regardless of histology, or do you prefer it for the squamous group, where I believe the hazard ratio was even more impressive, it was something like 0.48?
No, I absolutely like it for the squams a lot more. And you're right, I do offer it exclusively in that patient population, but I don't shy away from it in the non-squams either. Again, if they're completely PD-L1 negative, I think there's a legitimate area where the 227 with the ipi-nivo can be effective. I think that the distinction we might make is that the data still looks like the response rates are higher with chemo IO, kind of like the Keynote 189 approach for patients that have significant disease burden. The response rate, particularly in PD-L1 positive group, is really high. So it is a patient population that, it gives me a little bit pause when we see someone in the clinic with a lot of disease and very, very symptomatic. So I think that distinction can also be brought into clinical decision making.
Do you ever, when you use 9LA, Haas, do you ever extend the chemo beyond 2 cycles to 4? Or you always stop at 2?
I stop at 2. I'm going to try to follow the study as much as I can. And 2 or 3 cases that we've had so far that we've used, that's exactly what we've done, 2 cycles, and we have interrupted.
Then if they develop disease progression on ipi-nivo, do you then go to standard chemo alone, or do you continue one of the, you continue a PD-1 inhibitor?
I've continued one of the PD-1 inhibitors with chemo at that point. So because, we haven't exhausted the platinum option at that point if they progress. So then I can go to like a chemo IO and hope that the addition of chemo can rescue. So it does give me that flexibility.
And I think we've already stated that we would have equipoise comparing 9LA to histology-specific chemo, particularly in the less than 50% group. Of course, you're one of the leading PIs in the parallel trial, the Insignia trial, and 1% or higher. And I personally think it's probably best suited in the 50% or higher, comparing Pembro alone to the Keynote 189 regimen in non-squamous. Elaborate a little bit on that. I think most of the audience are aware of it, but perhaps not all.
Yeah, so the Insignia is a collaboration between ECOG and SWOG, and basically, honestly, all the cooperative groups are participating. This is a trial for patients with non-squamous, non-small cell lung cancer with PD-L1 at least 1% or higher. Patients are randomized to 3 separate arms. In arm A, we start with Pembro, and at progression, we drop Pembro and go to platinum doublet chemo. Arm B, again, we start with Pembro, but this time at progression, we add chemo to Pembro, which is a practice that I know many people are doing at this point. And then arm C is the control arm of chemo plus immunotherapy, again, copying Keynote 189, but only in PD-L1 1% or higher. The statistical design is basically initially like a non-inferiority between A and B, comparing it to C, with specific criteria to show that perhaps the approach of starting with one drug and then immediately adding chemo or going to chemo is not going to be significantly inferior to the chemo IO. And it allows us to actually compare PD-L1 50% and higher with PD-L1 1% or 1 to 49% and provide some data as to the efficacy in this approach. The audience might also be aware of the Fda analysis that was just presented at ASCO, basically using the available data from trials. Interestingly, the Fda data in 1% or higher, and again, Corey, I know you're aware of that, indicated that there were 2 trials with IO alone, and they used 227 as one because there's no chemo in it. And then there are 6 or 7 studies that have chemo IO, and clearly based on that analysis, survival of the 1% or higher seems to be better with the chemo IO. However, that's a retrospective analysis. Only 2 trials included IO alone, and subsequent therapies were not considered. So we're really not sure what happened to the patients who didn't get chemo, who progressed on these studies subsequently. So it still remains a question, and I think the Insignia can provide that information, which again, I think is
and they didn't break down that control group by Nivo alone or ipi-nivo. It would have been nice to have actually seen the separate numbers, and I think that deficiency of that analysis. And regarding your Insignia trial, the accrual is picking up, isn't that correct? Yeah. So it's a landmark trial, and again, it's a trial that industry is not going to do, but it's a critical question amongst practitioners that really has a practical analysis. I think there are final 2 questions, and we really do need to get moving. I think we only have about 20 minutes left, but Any exciting agents in the pipeline? Your thoughts on TIGIT, and then finally co-formulation of TIGIT, perhaps with some of the PD-1 or Pdl-1 inhibitors. You think this is a logical approach, or should we continue to give all these agents separately?
So first of all, about the TIGIT, am I excited? I think there is enough data to be excited about TIGIT. Obviously, we've been excited in the past and then been disappointed. So I remain optimistic that TIGIT can be another relevant target in lung cancer, perhaps even small cell included. But I think that is a valid checkpoint inhibitor that I think we're going to see a lot more on. So yes, I am excited about that. Is there an unmet need? Of course. We're not curing patients enough. We're not done. There's a lot of work to be done. So the unmet need continues, particularly in the second line space after chemo IO or after 9LA or after ipi-nivo. What are we going to do with our patient population? I don't think any of us are happy with docetaxel. And, quite frankly, in my view, the patients who are coming off of IO alone or chemo IO are still having, have really good performance status, and many of them are candidates for subsequent therapy. So what we're going to do in that space remains to be seen, but clearly in the frontline setting, as I said, the cure rates are still not there. But the sub-Q, I think the sub-Q approach makes a lot of sense from a patient perspective. The PK and all that is obviously a little bit different. I think establishing the safety and of this approach would be quite interesting and needed. But whether the core formulation is a way to go, when we do ipi-nivo, and if somebody has grade 3 GI toxicity, we usually drop the ipi and manage the toxicity, and then have the option of continuing with nivolumab. At least that's the way I have done it. If you have a co-formulated drug and you have a unique toxicity with one drug versus the other, it's kind of hard to continue with the other one that you don't think is contributing. Now, TIGIT might be slightly different. So my answer to the co-formulation is it depends on the target. There are co-formulations with two different drugs targeting two different pathways that actually could make sense and could be quite effective. But on the other hand, you can imagine a co-formulation with a CTLA-4, it could be a little bit problematic. So in my view, some of these drugs can be co-formulated with hopefully better efficacy and shorter infusion time and all of that. But that's a theoretical question and theoretical advantage from my point of view.
I'm concerned about co-formulation for the reasons you've mentioned, but TIGIT at least seems to be one of the agents, and not just a single TIGIT antibody, but there are multiple antibodies that are targeting TIGIT that are now being tested in the frontline setting. So for the dozens of agents, the immunotherapy agents that have been looked at now, whether this is the most promising or whether others are going to make the cut remains to be seen. I'm passing the baton to you, Haas. You have all of 18 minutes to finish up targeted therapy.
All right, but we have Caroline who's raised her hand. Can I encourage you to put your question in the Q&A and we get to it? Because it's kind of hard to go to a voice Q&A. I'm sorry. So thank you, Dr. Langer. Wonderful job as always, and I'm sure you could have taken the entire an hour plus to go over the data. So we're going to cover a couple of these targeted therapies. So let's get right into it. Next slide. First, we're going to look at the KRAS G12C and the CodeBreak 100 study. I think, again, the audience is very familiar with the fact that we now have the capacity to actually target KRAS, but it's not the entire KRAS, specific subtypes. In this case, we're talking about G12C. And again, the good news is that now that we've learned to target one subgroup, I think the rest are going to follow. And we have a phase 1 with the G12D particular inhibitor. So all of this is going to follow. But this particular agent, sotorasib from Amgen, has generated a lot of attention and a lot of press release and all of that because of the efficacy of the agent. This is an oral drug that specifically interacts with G12C and keeps it in the sort of a silent mode, if you will. We've seen preliminary phase 1 data. There was a New England Journal of Medicine article just 7 or 8 months ago describing the phase 1. This is sort of going in depth into the non-small cell lung cancer patient population at the recommended dose of sotorasib, which is 960 milligram a daily, 125 patients. There's no competitor here, but you see the distribution of patients on the table. I think it's important to keep in mind that clearly many of these patients had received prior chemo. Many of them have received prior immunotherapy. So there was evidence of progression in this patient population on prior standard treatments. Next. So we have the PFS and OS curves on the right-hand side. This is the first time we really have PFS and OS data in the lung cancer patient population with this particular agent. You notice that the OS is 12 and a half months based on 126 patient population, and that the PFS is a pretty respectable 6.8, almost 7 months. And again, for a patient population that has received prior therapy, I think this is very reasonable. The overall response rate is 37%. And again, those of us who have done a lot of targeted therapy, we sort of are accustomed to much higher response rate with other targeted agents, but we have to realize KRAS is not like the other targeted therapies. And also, please keep in mind that we could be witnessing the equivalent of the gefetinib for the EGFR in KRAS, and hopefully there will be more progress, and hopefully we'll have better drugs, and hopefully we'll be able to build on all of this. But as it stands now, on a pre-treated patient population, response is 37, which again, I am very happy about, because, what's my option? Docetaxel with a response rate of 10%. And OS and PFS here is also pretty impressive. A PFS of 7 months, I think, is very good. The disease control rate, meaning and taking stable disease into account, raises everything to about 80% with a fairly durable response, so about 11 months. So the patient is on it and they do respond. They can maintain that. Next. The efficacy, again, is looked at in specific subgroups of patients. I think it's kind of interesting, although the numbers are really, really low on the bottom, highlighted in red. In the interest of time, I'm not going to go through every single one of these, but patients who had prior PD-1 or Pdl-1 but no prior chemotherapy, the response rate is a little bit higher, approaching 69%, which again is kind of interesting. And the median OS is also better than the overall patient population. Now, is this something that should be tested? Is this something that we can confirm in subsequent studies? And I'm sure we're going to get additional data from other KRAS G12C inhibitors that are coming and catching up in terms of phase 2 data. So that will be a patient population that we can take a look at and see if this can be confirmed. Here, we only have 13 patients. It's kind of hard to get super excited about that, but interesting. As far as side effects is concerned, again, unfortunately, none of these drugs are going to be free of toxicities. We've learned to concentrate on severe toxicities, grades 3 and 4. These are the ones who usually lead to treatment discontinuation and other issues. And by and large, some GI toxicities, and about 5 or 6% of patients having LFT abnormalities in terms of rise in ALT and AST is observed. Now, the question is, are these patients really having any other symptoms, or are these laboratory manifestation of the drug? In the presentation, I didn't really hear a lot about patients actually having significant symptoms with elevation in their liver function test, and something to keep an eye on, obviously, if you want to combine this drug with other agents that could also have liver toxicity as a potential mechanism or as a potential side effect, then one has to be very careful about combining these agents. Next. Here, the presenters decided to dig a little bit deeper and look at further subgroups. And let's start with the left-hand corner, looking at TMB. That didn't seem to have much of an impact on the objective responses, as you see. Some of the co-mutations, such as P53, STK11, again, it doesn't seem to be a significant difference. But when you get to KEAP1, you see that, for KEAP1 mutant co-mutation present in the tumor, and that's shown in the lighter blue, the response rate now drops to around 20% as opposed to 44% in the KEAP1 wild type patient population. And on the far right side, again, you look at the co-occurring co-mutations with STK11 and KEAP1. Again, the reason we're interested in these two more so than anything else is that we see it in KRAS, first of all, KRAS population, and B, there's some information to suggest that especially KEAP1 mutation, when present, could be a harbinger of lower response, although I wouldn't say lack of response, but lower response to checkpoint inhibitors. Same thing with STK11, although not to the same extent in my view as KEAP1. But the double mutant seems to sort of have a really poor prognosis in terms of response rate and others. So these are the subgroups of patients that you're going to see concentration on future studies and combinations, because again, I think it is a patient population we're seeing now that we're doing a lot of next-gen sequencing, and we need to know how best to treat this patient population. Next. Okay, so and this is the FDA approval of the agent. We know that the confirmatory phase 3 of sotorasib versus docetaxel is ongoing, so we're going to have additional data. But I think this is a positive development, a drug that was needed in this patient population, and the very first salvo in this sort of particular problematic mutation, which is again, KRAS mutation is the most common mutation we find in the non-squamous non-small cell lung cancer, and the problem is the heterogeneity of this group. So a lot of interest, and I think, again, this is a very positive development. Next.
So if I could just interject here very briefly, Haas, I agree with you wholeheartedly. This is a breakthrough. This is a game changer. As you point out, this is the most common of the KRAS mutations. And if we do the math, the numbers with G12C equal or exceed what we see with EGFR mutations. So particularly in areas of the country where smoking rates are higher. So the potential impact is quite obvious. I don't think we're ready for frontline, at least not yet. The 13 patients you showed with prior Pdl1, with a 69% response rate is tantalizing, but we need a lot more phase 2 data, and that's a group where chemo IO may work as well or better, and may be preferential since it offers the chance of long-term survival. Finally, having personal experiences you've had, this is one of the least toxic oral agents I've worked with in the last 5 to 10 years, at least amongst those that I've treated. A lot of the hepatic toxicity is paper toxicity. It's had no bearing whatsoever on clinical outcome. And the KEAP analysis, again, is very small numbers, hypothesis generating. And I wonder if KEAP mutations are bad specifically in KRAS or just bad karma, period. Poor prognosis patients, but clearly that's a group that doesn't seem to do well. STK11, I think, is the jury's out.
Yeah, I think the KEAP1 is probably just a bad outcome regardless, but particularly in the co-mutation. So we actually have a question from Andrew Hong, who's asking exactly what you were referring to, Corey. How would you move this in the front line, and how do you use it in the first line setting? And again, we all acknowledge that IO chemo is really a high bar in the frontline setting. So the question really is, how do you design a study comparing these drugs in the frontline space? What do you combine it with? And my answer is, unless we have some safety data that you can easily combine sotorasib with either IO or chemo, and again, we can speculate given the toxicity, but I think we have to establish some safety rules first for these combinations. Then we can think about, taking this in a frontline. And I am a proponent of sort of identifying these particular subgroups, perhaps take the KEAP1, for instance, or the STK, and separate them from the other group and sort of proceed in a stepwise manner in evaluating the efficacy of this agent up front. But again, safety has to be established that you can, in fact, combine this drug with chemo and IO without significant toxicities.
And certainly our experience with CRIS and Nivo and outpatients in ROS1, and our experience with osimertinib and durva in EGFR patients is cautionary. We've seen heightened major increases in toxicity when given together. Although, again, that 13 patient group where they segued from an IO to sotorasib with fairly high response rates is a bit reassuring. But this is not ready for prime time. We need a lot more data.
Yeah. So capmatinib study was also again presented. This is the geometry study, as you know, in patients with MET exon 14 mutation. Definitely a patient population that if you do enough NGS and you have a robust enough platform, you're going to identify these patients. So the number one thing that we have to mention here is that if you don't look for these, you're not going to find that. I was discussing something with Dr. Ross Cambridge from Colorado, and he actually reminded me that, you know, when they went to a more on RNA-based assay, they were able to increase the number of MET exon 14 patients that they identify, sort of again suggesting that perhaps a more comprehensive DNA RNA analysis needs to be done to identify these patients. So nonetheless, a geometry mono has been presented at a couple of meetings, so we had an update. Standard criteria, these are all patients with advanced disease. They all have MET exon 14 mutation, and they were treated with a standard dose of capmatinib at 400 twice daily. There were several different cohorts, as you see, including patients in the frontline, so treatment naive group that were treated with capmatinib with the primary endpoint of response. We've accepted that for the kind of studies that we do with these targeted agents. Next. A really busy slide sort of going through various subgroups of patients, as you can see in cohorts 5, 4, and cohort 6. I mean, the good thing here is that now the experience includes about 160 patients, whereas in other presentations, we had much smaller numbers. So it gives you a little bit more confidence about not just the clinical efficacy, but also the safety of the agents as the number of patients increase. But the response rate of up to 66% is very much comparable to the other cohorts that we had seen previously in treatment naive patients. So again, to me, if you have identified a target and you have a targeted agent, my preference is always to use that target in the frontline setting. I think sometimes it's hard to get a sense as to whether in a second, third line setting, the efficacy is diminished or not. I mean, you look at numerical numbers, and to me, it looks like numerically the response rates are a little bit lower. Is that statistically significant or not? I cannot tell you. But my preference is that if I have identified a target and I have an active drug, my preference is to use it up front before I use chemo and IO, unless there's data to suggest that otherwise should be done. In the pretreated patient population, response rate is 52%. Again, really good responses. And you include third line patients, and now your response is 40. So this is what leads me to sort of say that you go from 65, 66% down to 50, down to 40 as you go through the lines of the therapy. So I would prefer to use it up front. The median OS of about 21 months I think is clinically meaningful in both treatment naive patients and 13 months in the previously treated cohort. So altogether, again, yet another agent in our armamentarium for a patient population that we do see in the clinic, but it does require a pretty robust NGS testing and comprehensive testing. Corey, any comments?
No, I agree with you. I've now using this up front. I think you're going to get into this shortly, but the toxicity is not negligible. We see a fair amount of GI toxin, particularly edema, which seems to be a class effect for all the compounds here, which you're actually showing at this point, the peripheral edema. I hate to say this, but this table soft pedals the degree of edema that is frequently encountered. And that doesn't seem to matter whether people are chemo exposed or treatment naive. The vast majority will have that. I guess where I have a little bit of question is somebody has had a high Pdl1 level, say 80%. Would you preferentially use this agent? Would you perhaps resort to Pembro in that group? And I'm firmly on the fence. I tend to use this up front. The response rate is higher The median survival is certainly quite reasonable, as good as we would see, or nearly as good as you see with Pembro, and it doesn't preclude segueing to Pembro later. But I don't think it's quite as straightforward as, say, EGFR, ALK, or ROS1 patients might be.
Yeah, I think there is some data in response to IO in this patient population. And again, it doesn't look to me like it's significantly better. And regarding the edema, I think, on the table, they're saying 75% of patients develop some peripheral edema, and, 10 to 11% are labeled as grade 3 or 4. But I think going back to your point, almost everybody who uses this class of drug actually gets peripheral edema. And I agree with you that it's kind of difficult to convey how disturbing it is for patients to have that degree of peripheral edema on a table like this. But nonetheless, the grading system is what the grading system is. But from a quality of life point of view, yes, we do have to pay attention to the fact that peripheral edema is a major side effect of this stage. So again, in the interest of time, we're at the hour. Let's move to the next slide. These are just the FDA approval for the drug that we just talked about. And then the next really exciting drug, and I really am excited about this, is this antibody drug conjugate to HER3. So patritumumab deruxtecan has been investigated. We've seen a couple of updates of this, but this one is specifically in patients who have developed resistance to EGFR inhibitors. And this antibody drug conjugate targets HER3, which is a very interesting target. I can tell you historically, from what I remember, other antibodies targeting HER3 never really had much of a clinical efficacy, but this is an antibody drug conjugate, so a slightly different mechanism. So patients here have advanced non-small cell lung cancer with EGFR mutation, EGFR TKI. Several different dose levels have been explored as part of this study. Altogether, as you see on the sort of the green highlighted area, 57 patients were treated with the 5.6 milligram dose in a dose escalation, and then 45 additional patients in the dose expansion. And I think that's the dose that presumably is going to go forward. The pooled analysis, again, is highlighted in the bottom. It's about 57 patients. The safety analysis is about 81, so still limited numbers. Next. Baseline characteristics, again, I don't think there's a lot to really talk about, except that everybody had an EGFR. 80 some odd percent, 86 to 89% of patients had prior osimertinib. Almost everybody, 80-90% had prior platinum-based chemo, and about a third to 40% of the patients had prior immunotherapy. And then on the right-hand side, again, pretty heavy treated patient population. If you look at patients with prior OSI, and prior TKI, as shown here, the confirmed response rate is 39%. A couple of complete responses, which we don't expect to see a lot of that in lung. None the rest, it's there. Pretty reasonable disease control rate, approaching about 70%, and a very quick time to response, about 2.5 months, which again to me is good. The duration of response seems to be a little shorter. I would have liked to see that to be a little bit better than 6 or 7 months, my personal view on it. But the PFS, again, is very respectable in a heavily treated patient population who unfortunately are not going to have a lot of other options. So a potentially interesting agent in a setting where, again, there is an unmet need, because you're talking about now post-TKI, post-chemotherapy, post-IO. And again, we wouldn't have expected IO to have that much of a response in an EGFR positive patient population. So very reasonable numbers, and we'll look forward to additional data coming for this agent. Next. Yeah, and these are the treatment-related adverse events. If you concentrate on the table with the sort of the bar graph, to quarter of these patients had some decrease in the platelet count that approach grade 3 or higher. So definitely something to pay attention to, with some neutrophil decreases, presumably as a result of the toxin, really, because the antibody moiety attacking HER3 shouldn't have this. Some fatigue, anemia, and again, more of a cytotoxic chemotherapy type of side effects, such as febrile neutropenia, have been observed. Next.
So if I could just make a brief comment, I think that's potentially going to be a game changer. I mean, 8-month median PFS in all comers after that degree of exposure. This is one of the first agents in the post-OZ era, where virtually everyone, 80% had OZ exposure, virtually everyone had prior chemo exposure, 40% had prior IO exposure, disease control rate of 80%, primary progression of fewer than 20%. But at the end of the day, there's still chemotoxicity that we're dealing with, as you point out, myelosuppression and other issues that come up with antibody conjugates. So it may be a tricky agent for the community.
True, yeah, but toxicities that we're familiar with. And then we're gonna end with another really exciting drug that just got FDA approval, amivantamab. This is a bispecific antibody that actually was approved very recently for patients with exon 20 mutations. Again, another subpopulation that we definitely see, and for whom we really haven't had very active treatments. And I know that Dr. Langer's institution and Dr. Josh Baumel have been heavily involved in the studies with amivantamab. So very exciting drug. But here we are evaluating the combination of amivantamab with lazertinib, which is another EGFR inhibitor, in patients who have osimertinib relapse, but who have relapsed after osimertinib treatment, but they're chemotherapy naive. And these are all, again, EGFR mutant patients with non-small cell lung cancer. Just a quick reminder, because it's a new drug, amivantamab comes in 2 different doses based on the weight of the patient, so less than 80 and over 80. And the dosing is, the schedule is weekly dosing for cycle 1 for 4 weeks, followed by every 2 weeks dosing, and lazertinib, which again, most of us in the US are not as familiar with, as an oral agent. The standard dose here is 240 milligram. Again, keep in mind that everybody had prior osimertinib, but they were chemotherapy naive, and everybody had to have an activating EGFR mutation. Numbers are kind of limited, but both NGS and ctDNA were used as entry criteria. Next. Again, limited numbers, about 45 patients. Again, the patient characteristics are shown. About 67% of these patients had exon 19 deletions, and about 30% had exon 21. Only 1 patient had the unknown. And based on a 45 patient study with a median follow-up of around 11 months, which is pretty decent, we have a response rate of 36%. A median duration of response almost 10 months, not quite there, 9.6. And the median PFS comes roughly around 5 months. Again, this is in a combination of 2 different agents. We go to the next slide. I think we're going to look at waterfall plots here, right? So patients who are identified with an EGFR and a MET, so keep in mind that amivantamab is a bispecific that targets EGFR and MET. You see that the response rate now is about 47%, as shown on the left-hand side. But there are only 17 patients in that particular subgroup. Patients who did not have an identified EGFR MET-based resistance, the response rate is a bit lower at around 29%, and that includes about 28 patients in total. Again, I think this is very intriguing, hypothesis-generating data suggesting that perhaps if we concentrate on patients that have known resistant mechanisms, the efficacy of this combination can be highlighted and perhaps magnified and draw benefit. However, I got to admit, 29% response rate in those who do not have a clearly identified resistant mechanism is still kind of interesting. So we have to see where the data lands, and we need additional information and more follow-up on this patients in this specific trial. I think toxicity is next. So if we go to the next one. Okay, so no, we're going to go to questions here. So I think we both agree, Corey, that the KRAS inhibitors are game changers, and definitely all of them who are in the clinic right now are probably going to get approved, and it is welcome news for that patient population. And the question of how to identify patients who would benefit from it in the frontline setting and how to move these drugs to the frontline is the next set of studies that are going to be conducted. Would you agree?
I absolutely agree, and I think choosing the control group in the phase 3 trials is going to be a bit of a challenge. This is a very high bar to beat. This is a population that may preferentially do well on immunotherapy. Certainly the early data with KRAS mutation suggested that. And two other major caveats. What about the other 50% of KRAS mutants that are not going to be targeted by adagrasib or sotorasib? There are a number of ongoing trials looking at new combos, but at least that's still 12 to 15%, maybe even 18% of that overall pie of non-squamous patients. Combinations, of course, are being looked at with checkpoint inhibitors, but with other inhibitors, including SHP inhibitors. So lots of data coming, a fair amount of skepticism, I think, moving this to frontline, but without question, established beachhead and second and third line. And as you pointed out, the CodeBreak 3 trial is directly comparing this agent to docetaxel. Unless something unexpected happens, I can't believe that sotorasib would prove no better than equivalent. I think at least the phase 2 data, which are fairly robust, suggest that it's going to hopefully do better than docetaxel in this setting.
Yeah. Moving on to MET, I think MET inhibitors clearly have a role in the management of patients with lung cancer. Obviously, MET has been, again, another problematic area. Clearly, MET exon 14 mutations can be very effectively treated with a couple of the available drugs. My preference still is to use them in the front line if I can, and I'll do my best to identify these patients up front. But MET amplified is a different story, and I think efforts in identifying best treatment options for patients with MET amplification is still sort of ongoing. To be honest with you, I don't think I'm all that clear as to what the role of some of the inhibitors are in MET amplified, but and I look forward to additional data coming in this setting.
And that's particularly cogent in the EGFR mutant population, where MET amplification can be a mechanism of resistance. And we've certainly seen promising data anecdotally for CRIS combined with the EGFR TKI for savatinib. And as time goes on, I think we'll see very similar data with both capmatinib and tepotinib.
Yeah, again, looking forward to that data. And again, you have to be on the lookout for all of this. So as far as TKI refractory, I'm assuming here you're referring to patients with EGFR mutations who have developed resistance to EGFR. I think first order of business is to identify what the resistant mechanisms are, because just as you heard from Dr. Langer, for some of these, like the MET amplified, there are trials and there are options that should be explored in the context of a trial that could have an impact on patients. So encourage everybody to get biopsies at the time of progression, particularly in this patient population, because again, we can do something when we identify a resistant mechanism. So I think that's a really important message to take home from all of the discussion. So what is the best option to go from there? It's a little bit of a debate. We have IMpower 150 telling us that the quadruple therapy could potentially be effective. There is a national study going on right now, multi-institutional study, looking into sort of trying to confirm what we saw in IMpower 150. That's being led by Dr. Joe Treat out of our institution, and many institutions of the country are participating. So that could be an option. Overall, immunotherapy alone is not a really good option in this patient population based on the evidence that we've had. Is it possible that other combinations, taking the resistant mechanisms, if identified aside, are there other options? And I think a combination like amivantamab plus lazertinib could potentially be something that moves in that direction. It's still a little early, but I think the result of the combination are sort of encouraging. I would like to know what the EGFR inhibitor is contributing to the activity in this setting. But I think we're on the right track, and we just have to be able to ask the right questions and find a place for some of these active agents.
I agree. The only two additional comments I want to make, Koss, when you say biopsy, it's not just tissue biopsy, but liquid biopsy in this setting.
Absolutely. Absolutely.
2 shots on goal, frequently uncovering mechanisms of resistance in the blood that we either don't see in the tissue biopsy, or the tissue's QNS, inadequate analysis, or too tough to really get an adequate sample. I agree. I think both patritumumab, but that's hard to pronounce, deruxtecan, and now this is lazertinib amivantamab combination, potentially put off our inevitable use of chemo in this setting. Up until now, PEM-carbo regimen has really been our standard. I tend to use PEM-carbo-bev off study or the Empower 150 regimen. And I think there's not... This whole setting of targeted therapy has really been incredibly exciting. You know, Haas is a relatively newer vintage oncologist compared to me, but more than half my career was spent before the modern targeted era, which really only began around 2005 with the identification of EGFR mutations. So again, to put all of this in perspective, absolutely none of this was even, it was glimmered, but it was certainly not realized until the last 3 to 5 years, at least for this wide range of mutations.
Agreed. And thank you for that perspective. And I think it is really important for all of us to keep that in mind. And I often say, when I was a fellow in Dr. Langer's clinic, we didn't have any of these options. None of this.
None of them.
And that honestly wasn't that long ago. I'm not that old yet. It wasn't that long.
We used to debate the dosing of taxane and whether to give it at 1 hour, 3 hours, 24 hours. We have clearly moved on. Thank goodness.
Thank goodness, exactly. And thanks to you and your colleagues who did pave the way for us to do all these studies. I think your contribution and your colleagues' contribution should be respected and counted in all of this, because without you guys, we wouldn't have gotten here. That's for sure.
Thank you.
Great, thank you so much. We can listen to you all evening, but I know you have better things to do, and especially Dr. Langer actually has to see patients, and Dr. Borgay was in the clinic all day. So thank you, panel, for staying over a little over time, and thanks for the attendees for joining. We do appreciate any last-minute advice for some of the colleagues that are joining who are deeply busy in developing drugs within the lung space. Dr. Langer and Dr. Borgay.
A last-minute advice.
Yeah, anything about drug development?
Stay true to your principles. You got to do the hard work. You got to do your homework. Do the phase 1s and phase 2s. You're not going to jump in with a new combination and suddenly defeat established standards. All of the data that we've shown you has been very carefully conducted, very carefully cultivated. So, but the field's wide open, and we certainly have so many more options and therapeutic venues than we had even 10 or 15 years ago. So if you have interest in academic medicine, the world is your oyster.
I would agree, and I would drive home the point that we need better biomarkers. The days of giving the same treatment to everybody who walks into the clinic is long gone. So I think we have to do a better way of identifying patients who are truly benefiting from all of these treatments that we're having, minimize toxicity, minimize cost to the healthcare system, and maximize benefit to those patients who would really benefit from it.
Absolutely.
Great. Thank you so much for your time, and the think tank table will be working on several different webinars as we go into ESMO. So the panel for lung, definitely please come back and shed light into the data as we see what happens at ESMO. With that, have a wonderful summer, be safe, and thank you for joining us.
Thanks, everyone. Bye-bye.
Good night.
Thank you. Good night. Stay well and stay safe.